Disorders of sexual development have often been considered as a medical and a social emergency. But what's been often ignored that it is actually an emergency for the doctors who rush towards going to the books to the various things as to how to evaluate an individual with DSD. iDSD will focus on the entire aspects of disorder of sexual differentiation, ranging from pathophysiology to classification to evaluation and management to iDSD, which is going to focus about disorders of sexual development, which is a very intriguing topic, a very interesting topic, which is often causing a lot of confusion with regards to evaluation and management. Website learning.growsociety.in, from which we are webcasting this event, where we have got multiple options available for learning in the form of our master pediatric endocrine course over 18 months, covering nearly now 100 modules on everything related to pediatric endocrinology. So if you want to learn, you've got each and every aspect which is there, using videos, using text, pre-test, case scenarios, and everything available. We have recently launched a pediatric endocrinology for postgraduate program, which again is covering a number of learning modules specifically for postgraduates for a 3-year period. All of you can have a look at a book which is available, and along with that we have the mobile application basically, which is covering in that perspective the various aspects of management of pediatric endocrine disorders, including the approach pathway, the management pathway, the personalized management care, and there are various ways you can use. It's a very intuitive form in terms of evaluating patients with different disorders of pediatric endocrinology. And these are available on Android and iOS.
Includes a wide range of the disorder, but after understanding of extensive physiology, pathophysiology by Dr. Anurag, now I think it will become easy. So XY disorder of sexual development occurs because of the defect in either gonadal development or testicular development, or because of the defect in gonadal function that include either impaired testosterone synthesis or its exon. And the disorder of sexual development caused by the impaired gonadal development include the various genetic defects, and that this includes the common one is the SRY deletion, though it is not as common as that is seen in XX female, but still it accounts for 10 to 20% cases. And SRY deletion can cause complete sex reversal with complete female appearance, and they present with the or they can present with a variable form of genital ambiguity, or it can be because of the early genetic defect like NR5A1, which is involved in adrenal development also. So it is associated with adrenal insufficiency, or they present with isolated XY DSD, or WT1, which is involved in renal differentiation plus differentiation of bipotential gonad into testis. So it is associated with renal abnormality in form of the mesangial sclerosis or congenital nephrotic syndrome, or very severe in form of Weger syndrome. It can also be caused by the distal genetic defect like SOX9, which is mainly role in Sertoli cell development, and it is also involved in skeletal development. It is associated with campomelic dysplasia, skeletal dysplasia, and or it can be because of the involvement of the other ovarian gene, which is actually antitestis gene, but if they are duplicated in XY individual, it will cause regression of the testicular tissue, and they present with the DSD. Now, most of this form of the genetic defects are associated with abnormality or variable abnormality of the Sertoli or Leydig cell, and they have variable presentation. So they have very heterogenic presentation. If it is very mild genetic defect, they just present with the micropenis, hypospadias, bifid scrotum, and genital ambiguity. If it is partial genetic defect, then they have combined Sertoli and Leydig cell function defective. So they will present with DSD plus some amount of the Mullerian structure may be there. And if it is complete, then there is a defective Sertoli, Leydig as well as germ cell function. So they present with complete female, normal female with strict gonads, and they are the differential of the primary amenorrhea. So we'll discuss the each and every defect in detail. So SRY deletion, which is accounts for 10 to 20% cases of the XY gonadal dysgenesis, and they have presentation in form of either genital ambiguity to complete sex reversal. They can also present with ovotesticular DSD, and they have highest risk of malignancy. So gonadectomy is essentially in the early stages of life if we identify this defect earlier. NR5A1, as it is also involved in adrenal development plus bipotential gonad development, it is if it is homozygous defect, it associated with combined adrenal and gonadal dysfunction. So they have adrenal insufficiency plus XY DSD, and if it is heterozygous defect, they just present with isolated XY DSD. And NR5A1 has also role in ovarian development. So as Dr. Chetan has discussed, it can also cause XX DSD. And manifestation include mainly in form of the genital ambiguity and adrenal insufficiency. They have low level of the testosterone because NR5A1 is also involved in Leydig cell function and testosterone synthesis. They can also cause ovotesticular DSD, and the presentation is similar like partial androgen insensitivity. Both the conditions should be differentiated, and confirmatory test is genetic testing. Because the management is different. For the NR5A1, they respond to testosterone, while partial AIs do not respond to testosterone. They need higher doses of testosterone for the management. So differentiation is essential in such cases. WT1 is involved in renal development plus differentiation of bipotential gonad. So its abnormality are associated with renal abnormality, and the defect may be variable in form of deletion, duplication, mutation, and their manifestation includes various syndromes. This includes the Dennis-Diss syndrome if it is associated with mesangial sclerosis, Frazier syndrome if it is associated with congenital nephrotic syndrome, or if there is continuous gene deletion, then they can present with severe form of Weger syndrome. This includes the Wilms tumor, aniridia, genitourinary abnormality, or mental retardation. Now, it is important to identify WT1 abnormality in XY DSD because it needs the lifelong surveillance for the renal abnormality and renal function. As sir has discussed, already discussed in first case, that baby just presented with XY DSD, but when we did genetic analysis, it came out to be WT1 defect. So this cases require the surveillance for renal function. It is essential to identify this defect. Now, SOX9, as I said, it is involved mainly in Sertoli cell development, but the presentation is variable, and it is also involved in growth plate development. They present with skeletal dysplasia, and that is mainly campomelic skeletal dysplasia. So it is considered in individual with DSD and skeletal dysplasia. Now, DEX1, it is mainly involved in ovarian development, but it has also role in adrenal development plus gonadotroph development in pituitary. So, duplication of DEX1 can present with XY DSD along with sometimes it may present with adrenal insufficiency and hypogonadotrophic hypogonadism in later life because its role in gonadotroph development. So all of these genetic defects, if we summarize, then WT1 defect is associated with renal abnormality, NR5A1 is steroidogenic defect and adrenal insufficiency. SRY is complete sex reversal, and it one of the common cause of the XY DSD. DEX1 duplication can also cause sex reversal, and it may associated with adrenal and pituitary involvement, and SOX9 defect is associated with skeletal dysplasia. So if these are the associated feature, we should think of the gonadal dysgenesis because of this genetic defect, and genetic analysis is required in such case. These cases are generally infertile, they don't have preserved fertility, and all these cases should be reared as male because of the some form of the the gonadal tissue is there. If there is there, then they should be reared as male. Now, XY female is actually the dominant. They are the complete female, but they have they present with generally primary amenorrhea. So they are like differential of the Turner syndrome. but their height is normal or even high on the higher side because of the Y chromosome, and they have gonadal failure, so they present with hypergonadotropic hypogonadism, and it occurs because of the various genetic defects like SRY, NR5A1, CBX2, and management is same like Turner syndrome, but they need gonadectomy because of the highest risk of the gonadoblastoma because of Y chromosome material. Now, anorchia is actually an intrauterine vascular event which leads to the regression of the testicular tissue, and if this event occurs before 6 weeks of life, by that time even Sertoli cells are not functioning, then both Mullerian structures are present and gonads are not there, means testis is not working. So they present with the complicated form of DSD plus presence of Mullerian structure. But if this event occur after the 6 weeks of life, then generally Mullerian structures are absent and their presentation is like genital ambiguity with no palpable gonads. So, and these gonads are generally absent. So, for identification of gonads, sometimes people are doing laparoscopy before doing the biochemical analysis. So, we should do the AMH and inhibin B before doing laparoscopy. If this metabolites of AMH and inhibin B are undetectable, it suggests that testicular tissue is not there and it does not require the laparoscopy. Now, persistent Mullerian duct syndrome, it is actually not DSD, but it is put here because it is associated with the impaired gonadal function. So here there is defect in AMH production or AMH exon. So AMH gene or its receptor is defective, and that's why there is persistence of Mullerian structure. The external genitalia are normal because testosterone synthesis is normal actually, but the gonads are actually not palpable or they may be higher in the abdominal region, and that is because of mechanical issue, trapping of these gonads in somewhere in the Mullerian structure in between fallopian tubes. So they have undescended testes. Now, after discussing these various genetic defects, which are the causes of XY gonadal dysgenesis, now we will move towards the various steroidogenic defects, which will cause low level of androgen production and presence with XY DSD. And this includes, the first one is the DHC, which is required for conversion of the 70 hydrocholesterol to cholesterol. And cholesterol is the first precursor which is required for synthesis of all the metabolites or all the adrenal hormones, that includes the aldosterone, cortisol and androgen, and it is associated with the Smith-Lemeli-Optiz syndrome. So they have low level of the androgens, aldosterone, cortisol, everything is low, so they present with salt wasting, or if the defect is mild, they just present with DSD and some syndromic features like upturnness, syndactyly, cardiac defects. Lipoid congenital adrenal hyperplasia occurs because of the early enzymatic defect of the star and side chain cleavage, which is required for the transfer of cholesterol to mitochondria and the first step of the conversion of cholesterol to pregnenolone. So if this defect occurs, they have low level of all the metabolites, so they have salt wasting. But as Dr. Chetan has discussed, that this salt wasting is generally delayed because there is destruction of the steroidogenic cells of the adrenals. So salt wasting is generally delayed, and they present with XY-DSD. 3-beta hydroxysteroid dehydrogenase, which can cause XY-DSD as well as XX-DSD, as discussed in earlier session, and it will also cause salt wasting if it is complete 3-beta HSD deficiency, but the onset of salt wasting is delayed by around 2 to 3 months of age. The 17-hydroxylase, which is required for the 17-hydroxylation of pregnenolone and progesterone plus further conversion of this 17 compound to the androgens. So if it is defective, it is associated with XY-DSD plus the precursor before this are accumulated, which is diverted to aldosterone synthesis. So they have accumulated aldosterone, and they present with hypertension with XY-DSD. Now, other distal enzymes which is required only for androgen production. This includes the 17-beta HSD3, which is required for conversion of androstenedione to testosterone. If it is defective, they present with complete lack of testosterone, so that they have complete female appearance, but they virilize during the puberty because of action of this androstenedione on androgen receptor. And other defects of the testosterone action, that includes the 5-alpha reductase 2 or androgen receptor defect, they also present with XY DSD. But here adrenal function is normal because there is no affection of the aldosterone or the cortisol. Now we will discuss all the enzymatic defect in detail. Now the LHCG receptor, which is the receptor which is shared by both LH and HCG for the functioning of the Leydig cell. So if this receptor is defective, then neither LH nor HCG can act on the Leydig cell to produce testosterone. So there is DSD, XY DSD. And depending upon the severity of the defect, they have variable presentation in form of genital ambiguity to the complete sex reversal. Biochemical presentation is in the form of low testosterone, high level of LH, because LH is not working on receptor, so it is accumulated, and a normal level of FSH. And actually, one of the important differential is there is no rise in testosterone level after HCG stimulation. So, which is also one of the diagnostic tests to identify LHCG receptor defect. Now, DHC7 receptor defect, this is caused by the defect in DHC7, and there is reduced cholesterol plus Leydig cell hypoplasia, and they have syndromic features in form of upturned nose, rotated ears, or microcephaly, syndactyly. So it is considered when there is DSD with adrenal insufficiency, with or without adrenal insufficiency and syndromic features. Or in every case of XY DSD, always look for syndromic features to identify the DHC7 defect, and they may be suspected if there is high level of the 7-DHC. Lipoid CAH, that is because of the star or side chain cleavage defect, which is mainly required for the earlier reaction, and that is conversion of cholesterol to pregnenolone. So they are associated with adrenal insufficiency and XY DSD, and they have a variable form of the salt wasting also, and all the metabolites are low, and there is no response to cyanoatine. 3-beta hydroxysteroid dehydrogenase 2 is mainly required for conversion of the progesterone to pregnenolone to progesterone, 17-hydroxypregnenolone to 17-hydroxyprogesterone, and DHEA to androstenedione. So it is required for synthesis of the all, that is aldosterone, cortisol, as well as androgen. So in the defect of 3-beta HSD2, there is low level of androgen. So there is XY DSD, plus there is salt wasting because of lack of the aldosterone plus cortisol. If the defect is milder, then they present with just XY DSD without salt wasting, and it can be suspected if the DHEA level is high. Now, 17-hydroxylase defect, as I discussed earlier, that there is defect in cortisol as well as androgen synthesis, but because of the accumulated precursors are diverted to the aldosterone synthesis, they have hypertension and hypokalemic metabolic alkalosis. So the XY DSD with hypertension, this is 17-hydroxylase defect, and if there is XX DSD with hypertension, then it is 11-hydroxylase defect. It is diagnosed by doing the metabolites of deoxycorticosterone or corticosterone. Now, 17-beta HSD3, which is required for conversion of androstenedione to testosterone, so it is testosterone synthesis enzyme. If it is defective, it is associated with complete sex reversal. So there is complete female appearance, but there is virilization of the genitalia during puberty because of action of androstenedione on androgen receptor. And it can be diagnosed by using this ratio of testo to androstenedione. If it is less than 0.8, it suggests 17-beta HSD3. So it is not reliable test. A genetic test is the final diagnostic. Cytochrome P450 Oxidoreductase, which is electron donor, which is required for the 3 enzymes, that is 17-hydroxylase, 21-hydroxylase, and aromatase. And in its defect, there is XY DSD or XX DSD plus salt wasting, and variable presentation can be there. It can also present with just delayed puberty and hypogonadotropic hypogonadism. They also virilize during the puberty, and they can be suspected when there is elevated level of 17-hydroxyprogesterone and progesterone. So the steroidogenic defects which are associated with XY DSD includes the DHC7 star and side chain cleavage and 3-beta HSD, which are the earlier defects. These are associated with the also impaired adrenal function. So there is salt wasting. 17-hydroxylase defect is associated with hypertension, while the distal defects of 17-beta HSD3 is associated with normal adrenal function and just XYDSD, incomplete sex reversal. POR, the presentation is variable. They have even salt wasting or isolated XYDSD. Now, after discussing this various abnormality which are associated with the defect in testosterone synthesis, now we will discuss the defect in testosterone XN. So 5-alpha reductase 2 enzyme, which is required for the activation of the testosterone. So testosterone is actually pro-hormone which need to be activated to DHT for its action. So as sir has discussed that in fetal life, because of the testosterone level around the Mullerian duct is very high. So around the Wolffian duct is very high because they are locally produced. So internal genital development is normal, but as the DHT is required for external genital differentiation and it is not synthesized in 5-alpha reductase 2 defect, so they have genital ambiguity with normal internal genitalia. And AMH is working well, so there is normal Sertoli cell function, so they don't have Mullerian structure. And it is suspected when the testo to dihydrotestosterone ratio is more than 10. This we can use basal or even HCG stimulated. But this is also not reliable test. Genetic test is the final diagnostic. And androgen insensitivity, where there is problem in androgen receptor itself. So androgens are there, but they are not working. And depending upon the severity, if it is complete, they present with complete normal female, and they present with primary amenorrhea, normal breast development, but sparse pubic hair. They have a hypogonadotropic hypogonadism and XY karyotype. If it is partial, they present with genital ambiguity, and if it is very minimal or mild defect, they just present with infertility or gynecomastia. Inefficient androgen XN, there are mainly two defects, 5-alpha reductase 2 and complete AIS. If we differentiate them, so the main defect in 5-alpha reductase is testosterone activation, while complete AIS is associated with defect in testosterone action. T-DHT ratio is high, more than 10 in 5-alpha reductase 2 defect, while it is less than 10 in complete AIS. At puberty, 5-alpha reductase 2 defects are virilized because of the action of the level of testo at puberty on the androgen action, but they generally feminize because testo is not working on androgen receptor, but the high level of testo get aromatized in peripheral tissue, and that will cause breast development in complete androgen insensitivity patients. Gender of rearing, preferably male in 5-alpha reductase 2 defect, while it is female in AIS. And Mullerian structure are absent in both the condition because Sertoli cell function is normal, AMH functioning is normal. And management is mainly with dihydrotestosterone in 5-alpha reductase 2 defect, while complete AIS, as we are rearing them and as female, they should be treated with estrogen, and gonadectomy should be done if they are abdominal gonads. Now, various drugs like use of various drugs in mother can cause DSD because of the disruption of the various endocrine pathway, and this includes use of diethyl stilbestrol, phenytoin, or phenobarbital can cause DSD, and they, depending upon the dose and duration of exposure, they have variable phenotypic presentation in form of mild genital ambiguity or complete female. And if we do the analyze such patient with the various endocrine metabolites are normal, so it should be suspected when there is everything is normal, still DSD, and if there is history of use of this